It's the end of the second day. It's always a little bit difficult, but you are here, and we have very interesting discussions now, the 3 debates. We start immediately with the first debate, and I would like to ask Professor Fonollosa Calduch to come to the podium. He is working in Bilbao.
Yes, sure.
And we are very happy to welcome him. And I think that he's the president of the Spanish UVEITIS Society.
Yes,
so,
yes.
That's good. And he will give the yes part of systemic therapy is the best option to control uveitic macular edema.
Okay.
Thank you, Alejandro.
Thank you very much. It doesn't work.
You have to
very hard?
Push it hard.
Oh,
yeah, it's like the elevator sometimes.
So, I think that first of all, we should explain what is control of uveitic macular edema to try to understand which is the best option to achieve this control of uveitic macular edema. So, I think that there are 2 clinical scenarios when we are talking about control. One is treatment macular edema, that is in the acute phase or when the patient comes to you with a macular edema. And the other clinical scenario when we are talking about control is the prevention of long-term recurrences of macular edema. So these are both different clinical scenarios, I think. So if we go to the treatment, the management of the acute phase of macular edema, and we are talking about a local approach, though many treatments exist in the literature and other fantastic molecules will arrive soon, I think that from a clinical point of view, we have nowadays 2 options, periocular steroids or intravitreal steroids. And if we go to the local approach to prevent recurrences of macular edema, we have ILUVIEN. If we go to the systemic approach to treat the acute phase of macular edema, we have 2 options, oral steroids or pulse therapy. And if we are talking about the prevention of long-term recurrences of macular edema, we have immunosuppressive drugs, conventional, so many of them, and we also have biologics. I think that all of us will be agree with this schema. So what is the best option for me? I wouldn't say the best option, I would say a reasonable option for systemic treatment in uveitic macular edema. In the acute phase, treating macular edema, why I think it's a better option or a more reasonable option? In cases of bilateral diseases, because it's more comfortable, more practical. In case of aphakic patients or patients with a ruptured capsule, because of the contraindication of giving Ozurdex. In cases of a not controlled glaucoma or with a damaged optic nerve because of ocular hypertension. In cases of pediatric macular edema or in young phakic patients, especially if previous local treatments have been tried because of the risk of cataract and because of the risk of making these patients presbyopic after surgery. In cases of post-infectious uveitic macular edema, this is not frequent, but from time to time we see macular edema after acute retinal necrosis, after toxo, and I don't want an intraocular steroid in these cases, although sometimes we have to do it. In cases where we don't have a clear diagnosis, where an infection can be underlying the etiology, and if we have to treat at the same time a systemic autoimmune disease. So I think in these cases, we will be more comfortable giving a systemic treatment. These commented issues apply also for the prevention of uveitic macular edema, but there are 2 more situations that I think that have to be considered. If we are treating macular edema, but apart from macular edema, the patient has or may present more severe and acute manifestations, ischemic vasculitis, severe retinitis, I would not put an ILUVIEN in these cases. At least I would put systemic plus perhaps adjuvant ILUVIEN in these cases. Why? Because in theory, ILUVIEN lasts for 3 years approximately, but we know that sometimes it's not, the duration is less, and we cannot predict the duration of the illuvin. So if the patient has a severe disease that can present a recurrence, and we only have a local treatment, illuvin inside the eye, perhaps we have problems. And also in the situation where macular edema is associated with a choroidal disease, in these cases I would put systemic for sure, plus minus adjuvant treatment, because illuvin does not affect or has not so effect on the choroid. Let's go some clinical examples. This is a 45 years old man with this unilateral ischemic vasculitis, and he presented this macular edema, which we treated with Ozurdex, the nice resolution of the macular edema, but we established conventional immunosuppressive in these cases, because if we put an illuvin to treat the macular edema, okay, but also to prevent the vasculitis, we don't know what will be the duration, and I think that it's better to treat with systemic these patients in this case. And also, regarding choroidal inflammation, we know that illuvin is very nice, very effective, and we liked it a lot to control the vasculitis and the macular edema, but it has no effect on the choroid. So in these cases, I prefer systemic plus probably intraocular steroid. But do we have evidence of the effects long-term of immunosuppressive drugs, systemic treatment? We have some data from the MOS study where the authors showed that at 5 years, the reduction of frequency of macular edema was the same for Retisert versus the systemic treatment. Do we know which immunosuppressive is better? We have some data from very few clinical trials. For example, the FAST study, which compared mycophenolate versus methotrexate, and this study found that they were similar at 12 months. What about the anti-TNF for treatment of macular edema? As usual in uveitis, we don't have robust evidence. Okay, this is very common in uveitis, but we have some nice clinical studies, for example, this from Switzerland, that show that at 4 years, here you can see the reduction of the thickness of the macula with blockers of the TNF-alpha. But I think that talking about biologics in the field of macular edema, I think that blocking IL-6 is a very good option. Some years ago, Alfredo Adán and his team showed the fantastic efficacy of blocking IL-6 in these cases of even recalcitrant macular edema. And this has been replicated in other studies. And there's some evidence from the study from the French group that showed that even tocilizumab would be better than anti-TNF drugs to treat macular edema. So this is important because I think that IL-6 is a cytokine that is pivotal in the pathogenesis of macular edema. So to conclude, when for me systemic is more reasonable, I would say, because in the situations where it's bilateral disease, and in the situations when we also want to treat systemic inflammation, it's more practical, more comfortable for the patient. In certain circumstances to avoid complications like glaucoma and cataract. Also in other special cases to decrease the risk of reactivations of infections or worsening of infections. I think that long-term control of choroidal disease, we have to do it with systemic treatment, although we can put an implant to control retina and macular edema. And we can predict with systemic treatment, we can predict the duration of the effect. And the duration of the effect will be the one that we choose with giving treatment, systemic treatment. And it's preferable in the context of those diseases that can show flares of severe disease that can cause severe structural damage for the retina. And in uveitis, we know that there will be many opinions, and every opinion will be right, so I'm happy to listen to your arguments.
Thank you very much, Alejandro. And now it's my pleasure to invite my co-chair, Professor Habot-Wilner from Tel Aviv, to give the no sight. Great, great, great. Every year we have this topic, and every year we have new data, so that's great. Any questions or comments on this very important topic of treatment of macular edema?
Adán,
Can go, Alfredo, go to the microphone.
Hi.
Please go to the mic. Oh,
So what's your protection with your steroids? Do you use Adcal D3 and omeprazole? That's what we use, PPI? To prevent the osteoporosis
we do use omeprazole, yeah? Yeah? What do you mean? What is it?
calcium, yeah.
Calcium, vitamin D. You have to watch up regarding the weight of the patients. You have to control the glycemia, hypertension, potassium, everything. We're doing like blood tests, right?
When do you do the DEXA scan?
So
DEXA scan? Densometry scan?
what?
Densometry?
No, densometry.
Yeah.
So to be honest, if you treat the patients for a long, long time with corticosteroids, you should do it.
How long?
So if you have patients that are like more than 4 months with high doses of corticosteroids, I think you should do it.
What's high dose? High dose is what?
But to be honest, I do not achieve this in my patients because I give them high dose of corticosteroids, but not for a long period. Because we have so many good drugs today that I think, in my opinion, we shouldn't give our patients high doses of corticosteroids for a long time. So it's very uncommon in my clinic to do it, to use high doses. Maybe others do something else, but...
Yes, in relation with this steroids dose and everything, you've shown some numbers of complications of steroids, hypertension, hyperglycemia, obesity. But of course, this happens if you don't use correctly steroids. So we have to use steroids to stop the inflammation, but long term, you always have to put immunosuppressive drugs. And when do you ask for the osteoporosis monitorization and so on? You have your internist or your rheumatologist. I mean, you have to work in a multidisciplinary unit, and that's their job. I mean, that when, I don't know.
So in the UK, we have a table. If it's more than 7.5 milligrams for more than 3 months, then we would do a DEXA scan. The reason I say it, because obviously a lot of our patients are young females, and then we do the DEXA scan, and they become osteoporotic or osteopenic, and then we have to refer them to the bone specialist. So I think it's quite important.
Yeah, but then how many of your patients use
more than 7.53 months?
And they're also on immunosuppression as well.
Yeah.
It's a very, especially with uveitic edema and they're losing vision, can be quite tricky. And then
it's not so common though to have like many patients on more than 7.5 for more than 3 months.
I think that if you work in a context of multidisciplinary approach with internists, rheumatologists, I think that this situation should not happen.
Yeah.
These doses, these high doses.
Thank you. Alfredo?
I think I have a philosophical question that for me is important.
Very important.
In my opinion, macular edema implies active inflammation. This is, for me, is very important. Because if the eye has macular
Have to
edema...
explain to the FDA.
Eh?
Explain to the FDA.
So this is important. And
I agree with you.
You agree? Because in many papers and many forums, I think the idea is macular edema is a complication. But macular edema implies that the eye is with active inflammation. So this is important in order to the strategy of the treatment. IL-6 is, in our experience, is a very good target. Probably for me, for the future, for macular, this is one important point: is effective for the macular edema and is effective for the inflammation also.
Absolutely.
Because this would be a very important point. But at the moment, when we started and we used tocilizumab for the cases of macular edema, at that moment we can't use ILUVIEN. I think it's other option, because if we prefer to use with Orthodex with the first line, especially unilateral cases. If the patient has bilateral case with macular edema, probably tocilizumab is a good option. But if the patient has, you need to put many Orthodex, I think ILUVIEN is other option. So you have to have all these options.
Yeah, you have all the options on the table. Thank you also for having cited our paper in ophthalmology comparing anti-TNF, but this was a retrospective study. The prospective study with its results is under revision in Lancet Rheumatology, and we hope that it will come out, but it's confirming the same, and it's also our impression. Yeah. It's not, our study is just a prospective study, but tocilizumab is superior to adalimumab for macular edema, at least. And coming back to macular edema, I agree with Alfredo, even though for the FDA, macular edema is a complication. But in real life, the patients we treat, they have macular edema because vitritis, vitreous haze is already under control. I'm not talking about naive patients. So, and this is why many studies failed, because they were just based on the vitreous haze and not the other factors and endpoints. So, thank you very much. Other questions? We are waiting for the local anti-IL-6 results. Yeah. We hope that this will be a new strategy. Yes, please.
I would be very interested to know what is your approach regarding the immune recovery uveitis and macular edema in that case.
Immune recovery uveitis.
Is it local or is it systemical approach? Would you have, I don't know, the guts to inject?
I must be honest, because I'm always honest. I don't see such patients anymore. No, I don't have patients with immune recovery. We have a huge HIV unit, so they are being treated. I don't have such patients, sorry.
It's very infrequent, but we've published one case. We gave the patient first time Sinolone, recurrence, then Ozurdex, recurrence, then ILUVIEN, and we've published it. But first line, I would try steroids or steroids just in case. But and also in the context of post-infectious uveitic macular edema, especially after ARN and syphilis and so on. And first line, perhaps I would try steroids, but later you have to put an Ozurdex. And we also published the series with Alfredo some years ago.
And you must be sure that the infection
that's
is
very
under
important.
Control on long term.
That for sure.
Not, you will be in trouble.
So the second debate is on post-operative macular edema may be considered and managed as uveitis. So Professor Bodaghi says yes.
So Alfredo, now I will give you my philosophy, okay, on macular edema. I think it's important because, as you know, use off-label of drugs is always very difficult, and we know that our retina colleagues, they treat a lot of patients with post-operative macular edema with local therapies. These are my conflict of interest. So what is uveitis? What is the definition of uveitis? This is a primary inflammation of the uvea, okay? You have to exclude masquerades, and either they are malignant or not, and infections such as endophthalmitis. But toxoplasmosis is also an infection. But we are not excluding, you have toxoplasmosis within the group, but not endophthalmitis. Because the primary target is not inflammatory. And we have more than 100 different types of infectious or non-infectious uveitis etiologies. And the post-operative macular edema is usually not included in the group of uveitis. We all agree. But where is the border? Where is the frontier? Is this still relevant today? Or was it just before, and why should we exclude it? So this is a real question we are asking ourselves, and I'm asking myself because some colleagues are saying if we are in trouble with the controls and regulatory bodies because we have injected the patient and it was not a uveitis, how can we manage that? So I try to look at this. This is a case of a patient very well operated, and he came 6 months later with this macular edema, no real inflammation, no real uveitis. And this is after acetazolamide and topical NSAIDs. He was doing well, and then when I stopped, he relapsed. And this is when you start to go in the chronic setting of post-operative macular edema. The IRIS registry was published last year, and I think this is important because now we know that about 1%, 0.8% of all cataract surgeries, procedures, will end up with a type of macular edema. So this is good to know on more than 3 million patients. So if you take the incidence, then you see that this is not a rare disease. And it's just cataract surgery. So it becomes nearly like uveitis incidence. But as we are very intelligent in uveitis, we don't want to have big topics with us. We like rare diseases. So that's maybe something I don't understand, but we need to think about. This is just to show the differences regarding the cases where they were routine, complex, combined procedures or not. Of course, when it was complex, you had more macular edema. And these are the post-operative complications in the CME cases, and you have a significant difference between the groups. The risk factors, we know them for a while with the diabetic maculopathy, RVO, epiretinal membrane, the use of prostaglandins, which is controversial, and uveitis, of course. And we know that if it's a uveitis prior to surgery, you will be in trouble. This is the subsequent procedures in the group, and this is just to show you that the visual acuity, even though you are treating the patient, it's not achieving the same result at the end, especially if you are not treating them rapidly. So why this has not been considered as a real uveitis? Is it because of the pathophysiology? Is it because of the natural history? Or is it because of the use of the therapeutic strategies? Or maybe the three of them? So I went back to history to see when it was first described, and at that time, this was the standard of care for cataract surgery, intracapsular, okay? So you see that it was not as smooth as phacoemulsification, and this is the first paper in '53 by Samuel Irvine. He published, it was the Proctor lecture in '52, and it was published in the American Journal of Ophthalmology in '53, and he described this vitreous syndrome following cataract surgery. And as you see, there were many complications, and the fifth one is development of postoperative macular changes. And there are a lot of beautiful pictures of what happened at that time when you had cataract surgery with all the complications, with the vitreous loss, the wounds, and all what you can imagine that we don't see anymore today, fortunately. And he had the increased incidence of macular degeneration in these patients you see that if you had a lot of complications, then the rate, of course, is going up to 1 patient out of 2 will end up with macular edema. And this is the incidence regarding age. Of course, it's more severe in the elderly. Then this is Nichols, just in the same issue of American Journal of Ophthalmology, still in '53, describing 6 cases, and it was very interesting to look at the pathophysiology he was proposing. And it's always easy to criticize, but we are not in '53, and he was saying that in these 7 cases of macular edema, 3 cases, the disturbance occurred quite sometimes after operation. 4 cases, this disturbance occurred at about the time of operation, and he suggests that the predisposing cause was a vascular dysfunction. So for him, it was not inflammatory, it was vascular, of the retina and of the choroid. And it suggested that the precipitating cause in some cases was anxiety of the patient. You can imagine at that time with intracapsular, you are anxious. Then you have to wait until '66 when Gass published the first cases with fluorescein angiography. And if you look at them, you see the pattern we have. This was in '66, and it was interesting. He summarized by saying that macular edema or papillary edema should be suspected in any postoperative case of cataract surgery. In the postoperative patient, the pattern has been described. Fluorescein studies demonstrate that the pathogenesis of the macular and optic nerve lesions involves leakage of fluid, that's for sure. And what's interesting in the fourth one, although the cause of this leakage is unknown, biomicroscopic examination of these patients implicates vitreous inflammation rather than direct vitreous traction on the macula in the pathogenesis of the disease. So for gas, at least the inflammatory parameters and triggers have been characterized. If you look at the treatment, of course, we talk about NSAIDs, we talk about corticosteroids. This is what we use in the patients associated with the topical or systemic acetazolamide. And again, we are dealing with inflammation. We are treating inflammation. And if you look, this is a survey on which options you have, therapeutic options you have for your patients. You see that most of them are anti-inflammatory drugs. And this is the French study which went out the end of last year. And the use of Iluvien, this is not cataract surgery, this is after vitrectomy and macular edema after vitrectomy. So we are more and more treating the chronic cases, the difficult cases with intraocular injections of Ozurdex or Iluvien. So we are using more and more corticosteroids. Maybe anti-VEGF could have an action in some of the cases, but we are going more and more towards this type of injections. This is a case, just a case report showing that you may be at the borderline. 83-year-old patient, uneven full cataract surgery, CME despite 2 injections of the dexamethasone implant, 2060. This is September 2016. This is the fluorescein angiography. Of course, you recognize gas and what he showed. And this is after Ozurdex. The only possibility to resolve macular edema was interferon and the use of interferon. So this was a real uveitis. It was not just a gas syndrome. To summarize, I would say that post-operative macular edema remains an important complication in an era of modern cataract surgery and posterior segment surgeries where patients, they don't accept this type of complications anymore. So many cases may resolve spontaneously. It's mandatory to detect the risk factors. Treatment must be adapted to each case. We need to treat early the patients, and this inflammatory, which to me is not a toxic, it's not a TAS syndrome, not a vascular condition, may be in the future included in the large group of uveitic conditions, but we need to work for that because it's not approved by everyone. Again, so thank you very much.
Now I'm delighted to have Professor Alfredo Adán saying no.
Thank you for the invitation. I think, as Bahram mentioned, post-operative cystoid macular edema is a complication after surgery, especially after cataract surgery, but the majority of the cases respond without treatment. That is important. There are a small percentage of cases, between 1% and 3%, that the patient has visual impairment for the macular edema. So probably in cases with cataract surgery, complicated cataract surgery, the percentage is about 8% of the cases. Different that I mentioned previously with the macular edema and uveitis, the idea is the problem in this patient is the macula, the edema. There is not intraocular inflammation in the choroid and in the retina, and probably because in the anterior segment surgery, probably we have cytokines and many factors in determinate patients that causes the macular edema. So this is an important difference because, for example, the first patient has macular edema in the OCT. The majority of patients we diagnose this cystoid macular edema with the OCT, But if you perform fluorescein angiography in this patient, there is not inflammation in the retina, there is no inflammation in the vessels, there is not inflammation in the choroid. The other patient has macular edema, but the patient has active inflammation. As mentioned previously, patient has a leakage in the optic nerve, and they are completely different. This is a post-operative macular edema, and this is uveitic macular edema. The angiography is completely different. So the treatment, as Bahram mentioned, is the majority of cases we treat with non-steroidal topical drops, and the majority of cases or topical steroid. And with this treatment, the macular edema responds quite well. There are a small number of patients that you can treat with subtenon, and there are other patients that you can treat with intravitreal dexamethasone implant or fluocinolone implant also. There is this other possibility. But all the patients, in cases with macular edema secondary to posterior uveitis, many patients, the majority of patients, requires systemic and intravitreal treatment. The patients with postoperative macular edema, they don't require systemic treatment. The cases which the response is not good with the topical treatment, in these cases we treat with a dexamethasone implant, and the majority of cases respond well to the treatment. There are a small percentage of patients that you need to re-inject. In those cases, we use a fluocinolone implant, the ILUVIEN implant, if we need to treat with many injections of Orthodex. This is the proposal, the treatment. The first line is topical non-steroids. You can use also topical. The majority of patients, this is a complete resolution with this approach, and you have a small percentage of patients that you treat with intravitreal treatment with dexamethasone, or other possibilities, the ILUVIEN implant also. But at the end, the response with the Orthodex or ILUVIEN is quite well, so the visual acuity has a good evolution with the treatment. This is a typical case, one injection with Orthodex, good result. So I think the majority of the patients, this is many cases limited condition, and if you treat with topical, the response is in the majority of cases a good response, but you can use intravitreal implants with also good evolution and good visual recovery. We have promising drugs for the future, as in the other talks mentioned. Vamikibart is an intravitreal IL-6 inhibitor. In cases of postoperative macular edema, when the drug is approved, we can use in a off-label fashion. But I think it could be another possibility that the advantage is you don't have intraocular pressure increase and no cataract. So it's other possibility for the future. So I think for all these reasons, I consider that postoperative macular edema is not a uveitic condition, probably inflammatory condition, yes, and you have managed in the majority of cases with local drops or intravitreal implants, and I think it's different than the uveitic macular edema. Thank you very much.
Thank you.
Any questions? Yes.
Hello. Sorry, my voice is a bit funny from being sick. Two questions I have. We know in diabetic patients that the rate of postoperative macular edema is a bit higher. How do you approach those patients? Do you have a prophylactic treatment, like you add an NSAID from the start? And the second question is, if you have a protocol in your units, the way you treat CMO, like when the patients come from the first time?
I don't know, Alfredo, but I don't have a prophylactic treatment. I try to operate a patient with diabetes and diabetic retinopathy when he's under control, and I don't know which percentage of hemoglobin you wait for, but I'm not for operating patients with high level of glycosylated hemoglobin. So this is first. And then I'm not injecting except in very severe cases when you cannot control them. Some people, they are treated, they are monitored, but we cannot control the level of diabetes. In those cases, I inject during surgery, but in most of the cases, no. And I will inject at the after surgery. It's not only diabetes, it's also blood pressure, all the risk factors. So this is the way I try to do. But Alfredo,
we don't have a protocol to treat prophylactic with a topical non-steroidal in patient with diabetic diabetic. If the patient has diabetic retinopathy, it's another thing, because the patient can, I think those patients has more probably possibilities of macular edema after surgery for the macular edema and for the diabetic retinopathy. Probably those cases you have to select, and probably you can treat prophylactic. And I think I agree with you.
I think that a very important approach is to have the fluorescein angiogram done, and then to understand if there is the Ivan-Gas syndrome, or if it's actually related to the diabetes itself. Because if actually there is worsening of the diabetes macular edema, we should treat with anti-VEGFs, and not only with topical corticosteroids and NSAIDs.
Sarah, you want to add something?
I just wanted to comment on the prophylactic treatment for patients. We actually, in the department, we give them NSAIDs for a longer duration after surgery. Usually we just use it for 1 month tops, and for these patients we give it for 2 or even 3 months. So it decreases the rate of post-surgical macular edema. And as for the patients who presented earlier or in their history with macular edema in the context of diabetes, then you want to maybe sometimes inject during surgery or maybe a month before, so you can be covered by the steroids during surgery.
And probably if the patient has a history of uveitic macular edema, and you have treated the uveitic macular edema, and the patient is with no macular edema, and the patient has cataract, and you perform cataract surgery, probably in those cases, probably it could be interesting to inject Orthodex in the same surgery.
This is what we do. We inject prior to surgery, 2 weeks, but some people are injecting the same day. Now, Alfred, the other questions I have? Yes.
It was the second question.
Oh, sorry, I forgot.
The second question, let's say, related to non-diabetic patients. They come at the first visit and they have macular edema. So what's your approach? Let's say you put them on drops, monitor for how long, kind of what would be the steps?
After surgery?
After surgery, yeah.
After surgery.
First review, post-op.
We start, it's very difficult to find systemic acetazolamide now. So, in France, we have some problems, not in Spain, but, they are not expensive drugs, so one day they will disappear. I don't know why, but this is life. Unfortunately, and we are not making them. So this is a very, very difficult point. So we try to use local therapy with dorzolamide and NSAIDs or corticosteroids. And then if after 1 month, if we have no answer, no response, then we go for local therapy. Injection, intravitreal injection. For some people, they do periocular injection of triamcinolone. So this is the, yes. And then...
Just regarding the use of Iluvien during post-surgical macular edema, they say that in the majority of cases, it's not supposed to last longer than 1 or 2 years, and you're injecting a treatment that is supposed to last 3 years. So what is your approach regarding this? I mean, only 20% of them will need longer durations, so I don't know. Would inject something that lasts 3 years for something that is not supposed to be, I don't know.
That's a good point.
I think probably in cases of post-operative macular edema surgery after, for example, retinal surgery or vitreous surgery, probably is worse. Is more difficult the management. There are patients, the majority of patients, the evolution is quite good with topical treatment. There are another patient that you inject one Orthodex and all is...
Yeah, I know.
But there are other patients, a small number, that you have to inject. And if I need to inject more than 2 Orthodex, I inject Iluvien.
Yeah. The thing is that not for macular edema, post-operative macular edema, but for some of my patients, I'm waiting after 3 years and they don't need to be re-injected. It was enough for 3 years. So you need really to have a case-to-case basis for the treatment. Alfredo, I found that your presentation was not in line with your philosophy that you mentioned previously. I don't know, but because your philosophy was that we are treating macular edema without ocular inflammation in uveitis, the first presentation.
Yes.
You remember what you said? And then in this I know that it was a debate and you had the no side. But do you agree that you can have macular edema? It may be inflammatory, but without active inflammation.
In those cases, in the cases of post-operative,
Yeah, post-operative. Yeah.
post-operative is macular edema without inflammation. It's other disease.
So what? Please explain, because then I'm interested. You didn't explain.
No,
what is the mechanism
I
for
don't
you?
know. I don't know. You know?
So that's interesting,
I don't
because
know
if we now go, you showed the angiogram. I agree that if you have an angiography with vascular leakage, you have inflammation. I agree, even though you don't have vitreous haze. But if you go, for example, you take patients with retinitis pigmentosa, they end up with macular edema, okay? I think that this is not inflammation, even though you may have some inflammatory reactions to the cells and the retinal cells which are degenerating, so that may be okay. But if you see macular edema and immune therapy, cancer immune therapy, then it's something inflammatory happening. The angiogram is, you have just macular edema and it's inflammatory. So you don't need, I think, always cells, you don't need always vascular leakage in order to be included in the inflammatory part of it. I'm not talking about uveitis, but in the inflammatory mechanism. Yes, Esther.
I was just
Maybe
going to
you
mention,
need to.
because I'm quite lucky to do a little bit of genetics as well.
Okay.
And I was surprised because I always thought, like you, like retinosis pigmentosa doesn't have inflammatory macular edema until I start to do the clinic. Because even my colleague was already sticking Orthodex in some patients with retinosis pigmentosa, and it worked. And then, so I started to say, well, if you are injecting less immunosuppressed patient, and I was not lucky with that. But then I started to use tocilizumab, and I have a few patients with very, very good results with tocilizumab.
No, I agree, but do you think that these macular, because they are mentioned as masquerades, they are not mentioned as uveitis. So
I think it's a mixture, and not all are inflammatory, but I think some patients with RP, they have inflammatory macular edema. And a way to know, or at least is angiogram. Yeah, if you do an angiogram and you have leakage,
is usually
but if you have leakage, it's more likely to be inflammatory. If you don't have leakage, then it's more likely to be non-inflammatory.
Exactly, I agree. And I think that in these patients, the main problem is the blood-retinal barrier, which is damaged. But it doesn't mean that there is like a huge inflammation, right?
And I don't give them tocilizumab, I give them Iluvien after Orthodex, and it's working very well.
Yeah. It was harder for me to get.
Yeah, maybe, yeah, that's, yeah. Okay. Zohar, I think that we...
So we can go to the last debate, last but not least. Inflammatory choroidal neovascularization may be treated by anti-VEGFs alone. So,
thank you
Professor
again.
Fonollosa, yes.
Yeah, when before preparing this talk, I was in the know. So I thought that Esther was very lucky because she was in the right side, and well. But I've reviewed some of my cases and some of the literature, and I can say that I'm not in the know, but just in selected cases I will be in the yes. So there is literature that suggests that immunosuppressive drugs have an effect on the evolution of the CMV, the inflammatory CMV. Pier Giorgio's Neri publication, Matteo Airaldi publication. Let's say that Pier Giorgio was very enthusiastic with this title, highly effective in the long-term control, 1.25 versus 0.39. I don't know, well, but there's some effect, okay. But there are also publications that show that the contrary, that in use of immunosuppressive drugs may increase the risk of CMV, though there not be a selection bias. So, it has a sense to immunosuppress these patients. Why? Because one of the pathogenic mechanisms of CMV in the context of posterior uveitis is inflammation, uncontrolled inflammation. It's true. But there are also other mechanisms, damage to the outer retina or choriocapillaris ischemia. And these both mechanisms are not, or are a sequel of inflammation, are a result or a consequence of inflammation, and there has not to be active inflammation. Let's see some cases. This is a 58-year-old woman who consulted for metamorphopsia in her right eye. You can see here an hemorrhage, but you also see many other things in the fundus, these deep, creamy, ovoid lesions. You all know that this is a birdshot with this classic angiography imaging, both in the fluorescein and in the androcenin, and she had this membrane, both in the structural OCT and the OCTA. So in this case, there's no doubt that immunosuppressive drugs will give her a beneficial effect for the membrane. Of course, we will immunosuppress this patient because it's a birdshot, but I think that it will have beneficial effects in her membrane. But the birdshot and membrane is not very frequent. We saw some cases, but the most frequent situation...
Was she 829?
Yes, of course, of course. Of course. The most common situation in the context of inflammatory CMV is this. Is peak or multifocal choroiditis. This is a 38-year-old woman who consulted for metamorphopsia, and she had these spots in the fundus, and she also had this membrane with the typical pitchfork sign. And here, I don't see active inflammation. I see a sequel of inflammation, these atrophic scars, and perhaps the inflammatory attack was many years ago, I don't know. At this moment, she has not active inflammation. I have to confess that I put her on immunosuppressive drugs, and I put anti-VEGF. Well, here, you don't see active inflammation. And I will show you a couple of cases where immunosuppressive treatment was not given because the patient refused it. This is a 66-year-old woman, hyperopic, who consulted in May 2019 for a metamorphopsia in her right eye. Here you can see the fluorescent, autofluorescence, and the OCT showing this fluid and this membrane. She needed 7 anti-VEGFs to control the activity of the membrane, and you can see here the autofluorescence. You can suggest that this recurrence of the membrane was because of a smoldering chronic subclinical choroidal inflammation. But I think that you should see something in the autofluorescence after so many, after this time, and we don't see anything. And we follow the patient, and this is the appearance exactly the same many years later. Another case, this is a 61-year-old woman who had laser in 1996. Ester and I were in the medicine school these years, and she received laser in the right eye, and this is a multifocal choroiditis or peak, and she consulted for metamorphopsia in her left eye in August 2017. 3 anti-VEGFs were enough to inactivate the membrane, and we followed the patients for the following years. And the appearance of the fluorescence was the same until 2020, where we saw this inflammatory lesion. Okay, here you have it. Typical hyperreflectivity breaking through the RPE. This is inflammation, but we decided to observe the patient, and the lesion became atrophic some months later. In 2021, the patient presented an activation of the NVC, and 17 anti-VEGF were needed to inactivate the lesion. 2 years later, the lesion was inactive, and you could think that so many reactivations are due to smoldering chronic subclinical choroidal inflammation. I would think about that. But this is the autofluorescence in 2023, and this is the one in 2021. This is not a trick. These are real autofluorescence, exactly the same. If we had here artificial intelligence, would corroborate this that this is the same, okay? And the other eye the same. So, from October 2021 till August 2023, multiple CMV recurrences and no inflammatory flares. So, well, we have not treated the patients, many recurrences, but without inflammatory flares. And just a commentary, and as a matter to remark, I don't know if you have paid enough attention to these patients, because these were not typical PIC patients, because they had thicker choroids, they have Pachy vessels. So these are not PIC patients, normal PIC patients. These are cases of pointed inner pachychoroidopathy, which is an entity that has recently been described by the group of Vittoria Cincinelli, and these are like PIC patients that with thick choroids. So perhaps the evolution of these patients is different, I don't know. So when anti-VEGF alone? Well, I think that when a damage to the outer retina, for example, chorioretinal scars, is presumably the main driver of CMV pathogenesis. And a benignal course may be an option, Some PIC patients have the same scars for years and they don't have activation of inflammation. But, however, I wouldn't take any risk in patients with only one functional eye, of course. So an interesting approach of observation and not giving steroids in these patients is the cases of pointed inner pachychoroidopathy, because we know that these patients have the risk to present fluid after giving steroids. Thank you very much, and this is my opinion.
Ester will give the no part.
Okay, so thank you. Yeah, I think I have the easy position.
This is a Spanish debate, huh?
Yeah. First of all, I want to clarify, in 1996, I was not in the medical school yet. I was in the school. I am.
College.
So, okay. Well, this is my financial disclosures. So we are talking about inflammatory CMVs. And the first thing, I want to mention one of my mentors, Andrew Dick, said to me when I told him, well, this membrane I think is inflammatory. And he said, no, every choroidal neovascular membrane is inflammatory, even AND. So let's start for that, but we are going to talk about the supposedly inflammatory ones. And as Alex has already mentioned, the most common CMV that comes to the mind as inflammatory is PIC, or multifocal choroiditis, that you know that there is a debate that they are probably the same disease. And it's clear in this image, that, and has already mentioned by Dr. Fonollosa, that in PIC we have different lesions. We don't only have the choroidal neovascular membrane, and sometimes it's actually quite difficult to distinguish which one is an inflammatory lesion and which one is actually a choroidal neovascular membrane. As you can see in this fluorescent angiography, the CMV is this one. Sorry, I forgot to put the animation, but the rest are also inflammatory membranes, and they also take the contracts and leak a little bit. Okay, so another picture just to show you how there are many lesions, and not all of them are inflammatory membranes in PIC. Sorry, I was too quick. And here we have, for example, a patient that already lost the vision in the right eye because of a choroidal neovascular membrane that was initially diagnosed of CSR and secondary choroidal neovascular membrane secondary to CSR, but obviously this is not CSR, and you can see the lesion that Alex also described that is breaking the RPE, and in this case, this was not vascularized in the OCTA, which is helpful to distinguish a membrane or not, and if you give the steroids to the patient, you can see that how the lesion disappears. So that's what's happening with prednisolone 60 milligrams. And this is another case of epimutes. So sometimes we can also have this kind of inflammation associated to PIC that is not really choroidal inflammation, but it's a sign that something else is going on. And just to show you that it can get better. And and we can have epimuse at the same time of multiple lesions in peak. And I think this is a sign that something else is going on apart from the choroidal neovascular membrane, and we probably need to treat it. Okay, just to show you the lesions, that they can be different. And this has already been published, so I was very lucky that I already have the paper to show you that actually it's better to treat with systemic treatment. And this is just looking to multifocal choroiditis and PIC, but if they show in the study when you associated immunosuppressive treatment, there is better visual outcome, and also the membranes has less reactivations. So yeah, so maybe if your patient was okay with 17 injections, but maybe it could have been okay with only 6. We don't know. And another case of inflammatory neovascular membranes is serpiginous choroiditis. And you see, maybe you don't see the membrane that good in the fluorescent angiography, but here in the color picture was very evident because there were some hemorrhoids around. And also, we can see it in the OCT, how she has the membrane with a little bit of subretinal fluid, and also was very clear in the OCTA. But in this case, I think it's easy to go for systemic treatment because obviously we only don't have the CMV, we also have an active inflammation of the serpiginous choroidopathy that we know that it can be a very devastating disease if we don't treat it. So this patient definitely needs systemic treatment apart from the anti-VEGF for the left eye. And this is another case. This is actually a very scary case that I know some of you already saw it because I saw it in some forums. That is a young patient, 8 years old, that he was complaining of headaches during the pandemic and then came out with this in the eye. And we can see in that area, there's actually also a CMV associated with all this inflammation. But if we take a look to the other eye, sorry, the CMV, just to show you that was actually a CMV in the OCTA. And as I said before, sometimes the fluorescent angiography is not that helpful in inflammation, but the OCTA can help you a lot to see if it's vascularized. And this is the other eye of the patient, that if we take a look closer, you can see how she has also a very huge vasculitis with hemorrhage around. So in this case, obviously, you need to treat systemically. You cannot only treat with anti-VEGF, but in this case, actually, as there was not active leakage of the CMV, we don't treat with anti-VEGF. We only treat with systemic treatment. And that's the response of the CMV after 6 months of treatment. Of course, the patient has a long story, but we never had to treat the CMV with anti-VEGF. And this is another case that also proved my point. This is an idiopathic inflammatory CMV. And this is how everything started. She was complaining of loss of vision in the left eye and went to see the medical retina clinic because he was a little bit myopic. So they start with off-label Avastin. And that's how it got with Avastin, worse. So then they said, oh, let's switch to Eylea. And so they switched to Eylea, then they switched to Lucentis. So 8 Eyleas after and 3 Lucentis after. This is how it was looking like. So it was like, you want to switch to Avastin, right? Again. But so that was the point that was referred to the uveitis clinic saying, yeah, maybe there's something else going on because it's not responding to treatment. So this is how it was looking before the so many injections. So we were there. So we said, like, let's put her on oral prednisolone alone. So the oral prednisolone alone did not make any difference either. So everything was a little bit delayed because also the pandemic was in the middle. But that's how she was after the pandemic and all these injections and a course of oral prednisolone. So we decided to put her in IV methylprednisolone and start immunosuppression with methotrexate. And this is the answer. So she's much better. Probably not ideal because probably we got there too late. But if you compare how it was looking before the IV methylprednisolone and starting methotrexate, you can see that she's now in much better place. And just to show you that there was actually a real CMV, just in case you didn't believe it. And we also have here I think Alex has also mentioned this paper by Pier Giorgio Neri, that they conclude with a retrospective study that early immunosuppressive therapy is good for preventing, for helping the control of uveitis CMV. So that's to show you that probably in the patient that I showed you before, I got late. This is another case of a recent case I saw. There was a young female, myopic, but only one lesion, nothing else. So we cannot probably call it peak yet. And this was a CMV, and it was treated off-label with anti-VEGF before. And that was the result. So she came back with another flare-up of the CMV. We started her with aflibercept and started her on oral Immurel. I'm not going to say azathioprine. I never say how to pronounce that one, sorry. So Immurel, and she has been okay with no CMV after already 1 year of treatment. And she had a flare-up between 3 months before. So that's what I wanted to say, and I'm happy to fight.
Very good.
Questions? Someone? Yeah, Sarah.
I think that there are many situations where you should ask yourself if there is active inflammation. For example, when you started showing, let's say, settled cases of peak with scars, so nothing's going on, and then you have the CNV, probably you could start with anti-VEGFs, and then you can wonder if there is really an inflammatory part to your CNV. Once you start needing many injections, then you can go back and say, okay, something's going on. I injected more than twice, so maybe I should add something. Otherwise, I agree with what you said and with what Andrew is saying, because actually if you work in the lab, if you take, let's say, a slice of the aorta and put interleukin-6 and TNF-alpha, you can get sprouting new vessels. So TNF and interleukin-6 are pro-angiogenic, so you're completely right.
Yeah.
Thank you.
I think that an important point is to use the fluorescein, the autofluorescence, as you showed us. I think that this is a very important point because it helps us a lot to understand if there is an active disease or not. And I think also the multimodal imaging using the OCT scan by itself help us a lot to understand sometimes if it's actually a CNV or maybe it's an inflammatory lesion, because there are some types that you can really see by using the OCT itself, what is going on.
Yeah, I think the autofluorescence is mandatory in these patients. Yeah. And one thing that we are observing, and that it has been published at Alejandro Bernizzi and collaborators, is that those patients, if you do autofluorescence in every visit and you compare with all the autofluorescence you have done, you can see that the atrophic lesions grow. But any atrophic lesion will grow. But it seems that inflammation may play a role. And I think that we could think that if we see a growing of these lesions, perhaps there's inflammation, and for us it's a criteria of activity. Perhaps we are over-treating these patients, but there's some evidence, according to Bernizzi's paper, that shows that this growing of the atrophic lesions may translate inflammation.
Thank you. Yeah. Yes. Please come to the microphone.
About your previous statement about retinitis pigmentosa patient with macular edema. So if they are not responding to dorzolamide topical and they are not responding to acetazolamide tablets, and you kind of don't want to put a Nosodex because the disc is already compromised and pale, how to refer for tocilizumab? To whom you refer, for how long they should be treated with tocilizumab?
Well, I'm unlucky to do also uveitis apart from genetics. So it's, in Spain, we usually have multidisciplinary teams, so it's very easy just to go to the rheumatologist and convince them to give tocilizumab to the patient. So I only did it in 3 cases. Just don't think I'm completely crazy. But I only did it in 3 cases. But the first thing you do is a fluorescein angiography, as we said, and if there is leakage, then is when you could think about that. And the other thing is also there are some trials that suggest that anti-VEGF that can be helpful also in RP macular edema. So what I asked actually Professor Michaelidis about that, because he did the trial with Eylea, and he said that if it's no answer after 2 injections, then you shouldn't carry on injecting because it's probably not going to respond to anti-VEGF.
And in case you start them on tocilizumab, the time, 6 months, 2 years, 18 months?
Well, I don't really have the answer, obviously, but I think the approach we are having is similar to the one that we are having in uveitis. So we usually aim for 2 years of control of the macular edema, and if it's okay in 2 years, we probably will start to increase the treatment interval. But I didn't get to the 2 years yet.
These are degenerative macular edema, so if you stop, it will come back. You need to continue to treat. And sometimes, we forgot, but sometimes local dorzolamide is, Azopt is working very good, three times a day. It's Now, I have 2 beautiful debates. I really appreciate it. I have 2 comments. The first one is that I think that you should consider patients with anatomical alterations of the Bruch's membrane, where you will have always mechanically the target for neovascularization, even without inflammation. So it's very difficult to identify those cases, but I think that these are the only cases where whatever immunosuppressors or corticosteroids you will give, you will not be, because it's an anatomical alteration. The second comment is on, I think both of you presented very nicely, elegantly, all the choriocapillaropathies. The thing is that probably both of you agree is that if you have a stromal choroiditis with neovascularization, then we treat. If it's sarcoid, then of course we have to treat with immunosuppressors, but for PIC, for serpiginous, for all those choriocapillaropathies, then the discussion comes, and I think many retina colleagues are treating just with anti-VEGF, whereas uveitis experts are treating with both. And the fact is that every time you have a relapse, it's not like a relapse of macular edema. Every time you have a relapse, your vision is getting potentially down. So this is why. These were a few comments.
No, I completely agree, but just one thing I'm thinking is like sometimes you wonder, should we treat with immunosuppression normal CMV, like AMD CMV? And just in that sense, there is a case with Sorsby retinopathy, you know that it's a, disease, a genetic disease that causes recurrent CMV, that the patient, I think, was on treatment for another reason with anti-TNF-alpha, and the disease got much better with the anti-TNF-alpha.
Yeah.
So
they are case reports,
always wondering.
But we are waiting for a case series or a trial to show the efficacy. Any comments, my co-chair, Zohar? No, anything else? Everybody was courageous. They are still here. They stayed.
Yeah. Thank you for staying with us. Thank you so much.
Thank you, and see you in Krakow.
Krakow next year.
Next year in Krakow.
Yeah.
Thank you.
Thank you.
Thank you very much. Thank you very much. Thank you.
Let's have some pictures.
Yes. Picture.